Let's dive into pneumonia. No doubt, you'll see this all over board exams in both inpatient and outpatient settings. That's because it's common in and outside the hospital, and it can be very serious or even fatal. This sketch is going to cover the presentation and workup of pneumonia in the immunocompetent adult patient. Check out our upcoming video on pneumonia in the immunocompromised patient for that side of the story. This story, on the other hand, takes place far, far away. 20,000 leagues to be exact. Pneumonia is typically broken down by where the infection came from. Community-acquired pneumonia, often abbreviated CAP, basically means pneumonia not acquired in the hospital. In fact, in case you can't tell, we're leagues away from the nearest hospital, with Captain Pneumo and his crew. Of the innumerable microbes out in the community, there's a relatively small group that accounts for most pneumonias. They're mainly comprised of bacteria and respiratory viruses. We'll also discuss a few endemic fungal pathogens that infect immunocompetent individuals. Keep in mind, however, that no pathogen is detected in about half of cases. So mysterious. Additionally, in an upcoming sketch, we'll discuss pneumonia in the immunocompromised patient. We'll encounter all kinds of strange fungi, parasites, and even a few bacterial and viral zebras. All right, let's introduce the microbes commonly associated with CAP. First up, we've got the so-called typical bacteria. Streptococcus pneumoniae, a gram-positive bacteria, is the most common bacterial cause of CAP and will be symbolized by the stripy pneumatic suit with infiltrating rusty lung spots. Remember, that's purple for gram-positive. Another common bacterium is Haemophilus influenzae, or H-flu for short, represented as always by an H-themed biplane. Red for gram-negative. CAP is less commonly caused by Moraxella catarrhalis, embodied by this kind of freaky-looking moray cat eel. Again, red for gram-negative. Staph aureus, that good old gram-positive coccis that seems to get everywhere, is also a less common though important cause of CAP. It's symbolized here by the golden staff. Nice find. All four of these bugs are common bacterial causes of eye, ear, and respiratory tract infections. Notice this, well, typical looking fish floating on by. Just a typical day doing the typical fish things that typical fish do. The term typical here doesn't necessarily mean the most common. It's more of a classic designation relating to the fact that these bacteria are easily gram-stained and cultured and are generally sensitive to beta-lactam antibiotics. Pfft, typical. Next up, it's the atypical bacteria. The most common of the atypicals is Mycoplasma pneumoniae, a teeny tiny bacterium with no cell wall, which means it's resistant to beta-lactams and can't be stained. It's symbolized here by this weathered sign that now reads Myco instead of My Gold. Mycoplasma is a common bacterial cause of both upper and lower respiratory tract infections. Next is Chlamydia pneumoniae, an obligate intracellular bacterium also associated with upper and lower respiratory tract infections. It's symbolized by a chlamydia clam. Because of its proteoglycan pore cell wall and the fact that it likes to hide inside the cell, Chlamydia pneumoniae is relatively resistant to beta-lactams and not easily stained or cultured. Keep in mind that these bugs are dubbed atypical not because they're rare, but because they have resistance to beta-lactams, can't be cultured using traditional approaches, and aren't seen very well on gram stain. They're just atypical. Kinda like this derpy-looking fish over here. Our third big group of pathogens that cause CAP is respiratory viruses, including influenza A and B, parainfluenza viruses, RSV, and adenovirus. The most clinically significant virus of the bunch is influenza, represented here by the influenza flying fish. Remember that respiratory viruses can cause a primary viral pneumonia or predispose the patient to a secondary bacterial pneumonia. We'll remind you later, don't worry. Fungi are a much less common cause of CAP in immunocompetent patients. These bugs are often associated with specific exposures, such as time spent in endemic areas. Although usually asymptomatic, the endemic mycoses, such as histoplasmosis, coccidiomycosis, and blastomycosis, also have the potential to cause acute lung infection. These and other fungi are also important players in the setting of pneumonia in immunocompromised patients. But we'll get to that in a future sketch. But before we dive into the clinical presentation and workup, I want to introduce the other big category, nosocomial pneumonia, or pneumonia that's acquired in a healthcare setting. When patients are admitted to the hospital, they get exposed to a whole new world of pneumonia-causing bugs. So the epidemiology is slightly different than in the community. Nosocomial pneumonia is divided into hospital-acquired pneumonia, abbreviated HAP, and ventilator-associated pneumonia, also called VAP. For pneumonia to qualify as HAP, it must have an onset more than 48 hours after hospital admission. That means no signs of incubating infection at the time of admission. Similarly, to qualify as VAP, patients need to develop the pneumonia more than 48 hours after endotracheal intubation. HAP and VAP are caused by a variety of organisms and can even be polymicrobial. Let this school of bubbly, red, rod-shaped fish swimming by the medical quarters of the ship represent the common aerobic gram-negative bacilli, including Pseudomonas aeruginosa, Klebsiella pneumoniae, Enterobacter and Acinetobacter species, and E. coli. The statue of Mona Lisa below represents Pseudomonas, frequently reported as the most prevalent bug in this category. This school of coxoid purple fish represents the common gram-positive cocci that cause HAP and VAP, including strep pneumo, just like in CAP. This time, however, Staph aureus is the predominant gram-positive microbe, as emphasized by that raised golden staff below. This includes methicillin-sensitive Staph aureus and MRSA. All right, after that little overview, let's get into our SOAP note. First, demographics. Older patients and those with chronic comorbidities are at increased risk of pneumonia, highlighted here by our ailing elderly captain. Pneumonia is a common cause of death in the end stages of a number of chronic diseases. Another helpful demographic tidbit. CAP caused by mycoplasma, an atypical bacteria, is more common in school-aged children than adults. It accounts for up to 20% of pneumonia cases in middle and high school students, and up to 50% of cases in college students. Next, symptoms. Pneumonia typically presents with fever and cough. Other symptoms include pleuritic chest pain and dyspnea. So-called typical pneumonia is classically associated with typical pathogens like strep pneumo, H. flu, Staph aureus, and aerobic gram-negative rods like Pseudomonas. The presentation is acute in onset with productive cough and purulent sputum. In contrast, so-called atypical pneumonia is classically associated with atypical pathogens, including mycoplasma, chlamydia, and legionella, in addition to viral and fungal infections. But more on that later. The presentation is more subacute and characterized by dry cough or watery sputum. However, it's important to note that the terms typical versus atypical pneumonia have limited clinical value, as they're not reliable indicators of which specific organism is causing the pneumonia. Whether it's a typical bacterium or an atypical bacteria or virus or fungus, the clinical presentation varies widely. Another sign to watch out for is delirium or fluctuating altered mental status, which can be precipitated by all kinds of infections in hospitalized patients, most commonly urinary tract, respiratory tract, skin, and soft tissue infections. Hospital delirium is especially common in the elderly. Remember, both Mycoplasma pneumoniae and Chlamydia pneumoniae are also commonly associated with upper respiratory tract symptoms, not just lower. We're talking bronchitis, which presents as prolonged intractable cough, laryngitis, pharyngitis, otitis media, sinusitis, and rhinorrhea. These symptoms can co-occur with the lower respiratory symptoms or precede them. Also, compared to other pneumonia bugs, Mycoplasma pneumoniae is more commonly associated with mild extrapulmonary findings, including a maculopapular rash, subclinical hemolysis with cold agglutinins, and a mild transaminitis. All right, let's say your patient had a typical flu a week ago. You know, the usual stuff: cough, fever, headache, rhinorrhea, body aches. Then she started to get better before experiencing acutely worsening fever and pulmonary symptoms. This is the classic scenario of secondary bacterial pneumonia. We've depicted its time course in the shape of the oxygen line. Starting at the influenza flying fish, flu symptoms begin to improve before acutely worsening again as it heads towards the bacterial side of the sketch. Secondary bacterial pneumonia is an important complication of influenza infection, especially in the elderly. The most common culprits include strep pneumo and Staph aureus, which is why the O2 line points directly to our staph and strep symbols. Group A strep and H flu are also common. Now, when I say Staph aureus, I mean MRSA too. At Sketchy, we symbolize MRSA with a merciless pharaoh. Community-acquired staph pneumonia of all types are seen in older adults. MRSA pneumonia, however, also presents in young, normally healthy patients infected with influenza. The clinical course is extremely severe and the mortality rate is high. Primary influenza pneumonia is when the influenza virus, rather than bacteria, infects the lung. This is even more severe, though uncommon. Instead of the classic timeline with improvement and then acute worsening of symptoms, characteristic of secondary bacterial pneumonia, patients with primary influenza pneumonia experience persistent and then progressively worsening symptoms, as depicted by this fishhook here, pulling the influenza fish higher and higher. Look for high fever, dyspnea, and even cyanosis. All right, moving on from influenza. Let's talk about aspiration. Aspiration pneumonia occurs when funky juices, like exogenous material, gastric secretions, or upper airway secretions, end up in the lower airways. For aspiration pneumonia to develop, the clearance defenses that protect your lower airways must be compromised. That means decreased cough or decreased glottic closure, for example. What can impair your airway clearance? How about altered consciousness? From alcohol, drugs, or anesthesia? Or maybe your patient has an underlying neurologic disorder, such as Parkinson's or prior stroke. And how about dysphagia? Caused by an underlying esophageal disorder, for example. And don't forget about patients who have an NG tube or are intubated. Upper endoscopy and bronchoscopy also predispose to aspiration. Other risk factors include protracted vomiting and poor oral hygiene. The most common form of aspiration pneumonia results from aspiration of bacteria from the upper airways or GI tract. It's traditionally been recognized that various anaerobic bacterial species, which normally live in the upper airways, play a dominant role in the pathogenesis of aspiration pneumonia. These anaerobes include Peptostreptococcus, Fusobacterium, Prevotella, and Bacteroides. Current studies, however, have revealed that purely anaerobic infections likely comprise the minority of cases. It turns out that aspiration pneumonia that occurs in a community setting commonly involves the typical cat pathogens that live in the oropharynx, such as strep pneumo, H. flu, and Staph aureus. If aspiration occurs in the hospital, the typical nosocomial pathogens are often isolated in culture, including Staph aureus and the enteric aerobic gram-negative bacilli. Kinda like HAP and VAP, don't you think? One characteristic feature of aspiration pneumonia is that many patients will have an infection comprised of mixed flora, especially in community-acquired cases. All right, instead of foreign bacteria sneaking down there, another less common cause of aspiration pneumonia involves aspiration of a toxic substance into the lungs. This is typically stomach acid. This can precipitate a chemical pneumonitis, which is not technically a pneumonia, but frequently sets the lungs up for a superinfection with the typical pneumonia-causing bacteria. In fact, many patients with witnessed aspiration or signs of chemical pneumonitis will receive prophylactic antibiotics, especially patients who become severely ill. Symptoms typically resolve with supportive management. Alternatively, a non-toxic substance can be aspirated, which results in a localized area of obstruction and atelectasis. This could be anything from a bit of aspirated steak at home to a bit of aspirated barium milkshake in the hospital. With prolonged obstruction, bacterial superinfection can occur. In the setting of aspiration pneumonia, expect pulmonary symptoms to arise a few days after the aspiration event. This is in contrast to symptoms that arise a few hours after aspiration, which indicates chemical pneumonitis. Foul-smelling sputum is characteristic of an anaerobic infection. The patient may even report that the sputum is bad tasting. All right, let's ask a few pertinent past medical history questions. Assess for a history of COPD, which is a risk factor for pneumonia. Particular bugs include your typical strep pneumo, H. flu, and Moraxella catarrhalis. However, patients with COPD are also at higher risk for multi-drug-resistant gram-negative bacilli, including Pseudomonas. So we've put this big blue bloated fish next to Mona Lisa over here. Anatomic defects, obstruction, CF, and pulmonary infections can lead to bronchiectasis. Patients with bronchiectasis are at risk of recurrent pneumonia and are at particular risk of those same resistant gram-negative rods, including Pseudomonas. Patients with cystic fibrosis are particularly susceptible to pneumonia since they have difficulties with mucus clearance. The most common cause of pneumonia in patients under the age of 20, it's Staph aureus. After the age of 20, it's Pseudomonas, yet again. Recurrent pneumonia in the same location may be a sign of lobar obstruction, possibly due to a malignancy. Patients with repeated episodes of pneumonia merit further workup. All right, let's move on to some social history. Be sure to ask your patient about their living situation and lifestyle. Mycoplasma pneumoniae is transmitted by respiratory droplets in close contact situations, which explains the predilection for patients in close quarters like school children, college students, and military recruits. An important consideration for all patients with respiratory symptoms is the possibility of active pulmonary tuberculosis. So we've brought back our recurring cavitary lung cactus, or coral, I guess. Make sure to assess for the following when taking a social history: contact with known TB cases, travel or birth in a region with high TB incidence, prior positive TB test result, illicit drug use, and exposure to high risk communal settings like prisons and homeless shelters. Ask about the classic symptoms: fatigue, weight loss, night sweats, and hemoptysis. There may be extrapulmonary symptoms as well, like spinal pain from pot disease or headache due to TB meningitis. Check out our upcoming TB video for more information on the clinical presentation of TB. We are not done yet, though. There are a few other exposures to ask about in order to evaluate for some of the more unusual bugs. This Legionnaire over here represents Legionella, an atypical bacterium associated with contaminated water and ventilation systems. Suspect Legionella if an outbreak of pneumonia has occurred in a hospital, apartment building, hotel, or cruise ship, for example. You might also want to ask about exposure to other water sources, such as hot tubs and fountains. Legionella pneumonia presents more like an atypical pneumonia with a delayed onset of pulmonary symptoms. And although no signs or symptoms can reliably distinguish Legionella pneumonia from any other type of pneumonia, there are some suggestive features. Legionella pneumonia is commonly associated with extrapulmonary manifestations, including GI symptoms like nausea, vomiting, and diarrhea, and even neurologic symptoms like headache and confusion. Legionella infection is also classically associated with a relative bradycardia despite high temperature, hyponatremia, represented by this Legionnaire spilled salty sodium peanut treasure chest, and even a mild hepatitis causing elevated hepatic transaminases. And who doesn't have that one bird fancier patient? You know what I mean? Chlamydia psittaci infection, also known as parrot fever, is associated with exposure to birds. Infection commonly presents with fever, severe headache, and cough. Let this cracked skull next to the parrotfish remind you of that characteristic headache. And what's up with that curly Q sheep eel, you ask? If your patient has exposure to large livestock like cattle, sheep, and goats, think about Coxiella burnetii. You might remember from Sketchy Micro that this can cause Q fever. Well, turns out it can also cause pneumonia. Common symptoms of Q fever include severe headache, dry cough, and fever. Yep, that headache again. So remember that cracked skull. Travel can expose patients to a few classic endemic fungal infections as well. Let's start with Histoplasma capsulatum, a dimorphic fungus. Represented here by this deep sea diver referencing a historical map of the caves. Histo is found in soil contaminated with bat and bird droppings. So ask about exposure to caves or chicken coops. Specifically, it's most prevalent in the Midwest and East Central US along the Ohio and Mississippi River valleys. That's just where Histo likes to hide. The vast majority of infected patients are asymptomatic. Of the 5% that do develop symptoms, the symptoms usually arise several weeks following exposure and are mild. The ensuing fever, chills, headache, myalgia, chest pain, and cough are similar to other causes of CAP, though some patients develop an acute severe version of disease with excessive exposure. A small minority of symptomatic patients will develop arthritis or arthralgia, sometimes with painful skin nodules, particularly on the shin, called erythema nodosum, or target-like lesions called erythema multiforme. Next is blastomyces, another dimorphic fungus, represented by our next diver with the blast detonator device. As that blast creates a plume of soil, remember that blastomyces is transmitted through inhalation of mold spores that are found in soil. Typical patients include individuals with outdoor occupations or patients living next to areas of disturbed soil, like a construction site. Blasto is endemic to the east central U.S. along the Ohio and Mississippi River valleys, as well as the Great Lakes region. Systemic disease, aka blastomycosis, can manifest 3 to 6 weeks after exposure. The systemic infection predominantly affects the lungs, presenting as a chronic pneumonia. Extrapulmonary disease is variable. Skin disease is common, characterized by verrucous skin lesions that can resemble squamous cell carcinoma. As we'll see on imaging, disease can also involve the bone. And finally, coccidioides. It's kind of like the histoplasma of the desert Southwest. Mold spores hang out in the soil and get airborne when the ground is disturbed. Inhalation of spores can cause a self-limited acute PNA in otherwise healthy individuals. It's colloquially termed valley fever, and it occurs 1 to 3 weeks after exposure. In many cases, the disease is subclinical, and only about half of patients will seek medical attention. Pulmonary symptoms are typical of a community-acquired pneumonia, though arthralgias and skin manifestations, such as erythema nodosum and erythema multiforme, can also occur. Note that we've placed all three of these fungal explorers around the cavitary TB cacti. Let it remind you that histo, blasto, and cocci can present chronically, mimicking TB. Instead of the usual acute pneumonia symptoms, some patients will present with constitutional symptoms such as fever, fatigue, drenching night sweats, and weight loss over weeks to months. In fact, you may even see cavitary lesions, just like in TB. We'll reiterate this over in the objective section. Get excited! Also, all three of these fungi can cause severe disseminated disease, more commonly in immunocompromised patients. That, however, will be saved for our immunocompromised lung sketch. Now, since we're getting all cavitary over here, I just want to mention that, in addition to the common presenting symptoms we noted earlier, hemoptysis can also occur with any of the pneumonias, though it's especially characteristic of that nasty MRSA-associated necrotizing pneumonia, as well as the pulmonary infections associated with cavitary lesions. This includes TB, as well as the chronic forms of histo, blasto, and cocci. Alright, let's move on to some general objective findings. The majority of patients with pneumonia will be febrile. Patients often have tachypnea too. Tachypnea may be one of the most sensitive signs to look out for, in fact, especially in older patients. Depending on the type and severity of pneumonia, some patients may present with hypoxemia, as evidenced by a decreased oxygen saturation on pulse oximetry. This is a sign of ventilation-perfusion mismatch due to intrapulmonary right-to-left shunting of blood in areas of alveolar consolidation. Chest examination may reveal crackles or rhonchi. These are classically localized to the involved lung area, but may be diffuse. Just think of the crackling sound of Velcro tearing off a diving suit. Patients may also have signs of consolidation on physical exam. These include dullness to percussion and increased tactile fremitus. On auscultation of the area overlying the consolidation, you may notice that normal breath sounds are faint or absent. However, you may also hear bronchial breath sounds over the consolidation. These are harsh, large airway noises normally only heard on auscultation of the trachea. The consolidated lung transmits sound better than normal lung. As a result, large airway noises are conducted all the way to the lung periphery. Also listen for agophony, which occurs for the same reason: increased transmission of sounds through the area of consolidation. Direct the patient to say "e." If a consolidation is present, you'll hear a nasal sounding "a" on auscultation of the involved lung area. Chest X-ray is the most important initial test in patients with suspected pneumonia, and various features of the chest X-ray can suggest one etiology of pneumonia over another. In general, an infiltrate on chest X-ray is required to diagnose pneumonia and clinches the diagnosis when other supporting clinical features are present. The infiltrate can have a variety of radiographic appearances. One possibility is lobar consolidations. This finding is classically associated with the typical CAP, HAP, and VAP bacteria, but it's not a clinically useful marker for any specific microbe, typical or atypical. You might also see patchy interstitial infiltrates, which are often bilateral. These findings are classically associated with viruses, atypical bacteria, and fungi. But again, these findings cannot reliably differentiate between causative organisms. You might even see a parapneumonic effusion, which is present in about 40% of bacterial pneumonias. Many of these resolve without complications. Large, persistent effusions and effusions with an air fluid layer suggest a more complicated etiology. Imaging in the setting of aspiration pneumonia will characteristically reveal infiltrates in dependent areas of the lung. In upright patients, that means the basal segments of the lower lobes, while patients primarily in the supine position are more likely to have infiltrates in the posterior segments of the upper lobes and apical segments of the lower lobes. Just like this dependent jellyfish here. Remember that nasty community-acquired MRSA pneumonia? It's associated with nasty multilobar cavitary lesions as well as empyema. Just nasty. Our symbol for empyema, a snail stuck onto the pleura of that pharaoh, is pretty cute though. Think of that snail shell as a walled-off abscess. As for TB, cavitations in the apical segments of the lungs are associated with reactivation tuberculosis. In contrast, a diffuse reticulonodular pattern, known as a millet seed appearance, suggests a progressive primary TB infection or the reactivation of a latent site. This is called miliary TB, and it's depicted by the diffuse nodular spines on the cacti. Also keep in mind that histo, blasto, and cocci can present chronically, mimicking TB, with constitutional symptoms and everything. In fact, on imaging, you may even see cavitary lesions, just like in TB. See those mysterious pale eyes staring at us from the cave, resembling two huge worrisome hilar lymph nodes? If you happen to see enlarged mediastinal or hilar lymph nodes with focal opacities on chest radiograph, Think tuberculosis, histoplasma, or coccidioides. In addition to affecting the skin, blastomyces can also affect the bone. We're talking osteomyelitis. On radiograph, areas of bone involvement may show up as well-circumscribed lytic bone lesions. Any bone can be involved, in fact, though the vertebrae, pelvis, and sacrum are the most common sites. Vertebral disease can even look just like tuberculosis, with vertebral body involvement and destruction of the disc. All right, let's finish up this expedition with a few pertinent labs. See that leftward swimming school of fish with the occasional banded pattern? On CBC, most patients with pneumonia will have a leukocytosis with a left shift, also called bandemia. Though keep in mind that elderly patients may not manifest the same kind of leukocytosis and fever. They may have mental status changes, though. As we'll discuss in more detail in the next video, stable patients with CAP can often be managed in the outpatient setting. In these cases, further diagnostic testing are often skipped and empiric antibiotics are started. On the other hand, patients hospitalized with CAP, and in all cases of HAP or VAP, will require further diagnostic testing. This includes blood and sputum cultures, as well as sputum gram stain. In many institutions, a serum procalcitonin level is also collected as a part of the workup in patients with known or suspected CAP. Procalcitonin is represented by the tone being emitted from this treasure tracking device. Procalcitonin is a biomarker of bacterial infection, so expect it to be elevated in bacterial pneumonia, but not in viral pneumonia or non-infectious conditions. Check out our next sketch where we describe how it might be helpful for management decisions. Viral diagnostic tests can be particularly useful during cold and flu season, although the specific tests vary among institutions. Options include a rapid flu test, represented by the priceless nasal swab artifact tumbling out of the treasure chest, or a viral panel that can detect influenza, adenovirus, parainfluenza, RSV, and others. It's represented by this diverse selection of precious jewels shaped like viral capsids. All patients with moderate to severe CAP, or CAP that requires inpatient management, will also receive urine antigen testing for strep pneumoniae and Legionella. That's why we've placed this urinary canteen between the pneumatic pneumodiver and the decaying Legionnaire. Additionally, any patient with CAP or nosocomial pneumonia who has a possible exposure to Legionella should get tested. For patients with suspected fungal pneumonia, including those with recent exposure to endemic areas and suspicious signs on imaging, specific fungal testing can be undertaken. This includes cultures, antibody testing, and serum or urine antigen testing. Pneumonia is a super common condition, so chances are, if you're suspecting it, you're probably right. That said, there are a few conditions you should probably rule out before you start treating your patient for an infectious disease. One of the most important conditions you should consider and rule out before you settle on a diagnosis of pneumonia is pulmonary embolism, because it can kill your patient if it's not discovered quickly. Typically, patients with PE don't present with fever. Additionally, they often have symptoms or signs of a DVT, such as lower extremity pain, swelling, and erythema. A patient with big risk factors for DVTs, such as recent surgery, immobilization, or cancer, should raise red flags that you should rule out a potential PE. If you do have suspicion for PE, do further testing with a serum D-dimer level or a chest CT, depending on how likely you think it is. Diagnosing PE can be tricky, so check out our sketch dedicated to it in the pulmonology unit for all the details. Next up, make sure those lung findings are actually coming from the lungs. Cardiogenic pulmonary edema, from chronic or more commonly acute decompensated heart failure, can often mimic pneumonia in its presentation. Fortunately, there are a bunch of things to look for that can help you distinguish heart failure from pneumonia. Some of the most specific ones include an elevated JVP, S3 gallop, high serum BMP, and the characteristic fluffy bibasilar infiltrates seen on chest X-ray. Take a quick gander at your patient. If they look super sick, enough to land them in the ICU, they might just have ARDS. This one is kind of cheating, since technically ARDS can be triggered by an infection like pneumonia, but it's still something you should keep in mind in a critically ill patient since it'll change how you manage them. One feature of ARDS that can help you distinguish it from regular old pneumonia is its diffuse nature. Whereas pneumonia typically produces a focal set of findings, ARDS causes bilateral pulmonary edema, which results in diffuse crackles on lung auscultation and bilateral infiltrates on chest X-ray. Of course, you shouldn't forget about the possibility of cancer. Lung cancer typically presents rather insidiously, but if a patient with a significant smoking history presents with cough and hemoptysis, you've got to keep lung cancer on the differential. Usually, however, lung cancer looks pretty different from infectious pneumonia on chest imaging. There are actually fancy calculators out there that can predict the probability that a lung nodule is cancerous using basic patient info and imaging findings. But that's a topic for our lung cancer chapter. Lastly, there are a couple of much less common non infectious conditions that can mimic the presentation of pneumonia. One of these is drug induced lung injury, which affects a small proportion of patients who take drugs such as amiodarone, bleomycin, methotrexate, and nitrofurantoin, among others. A careful and thorough medication history will help you identify drugs known to cause lung toxicity and push you towards this diagnosis over pneumonia. The other super uncommon mimicker of pneumonia is interstitial lung disease. Now, because it's so rare, you shouldn't go off looking for it if you think your patient has regular old pneumonia. But if you get a curious occupational history, like shipbuilding, aerospace work, or coal mining, maybe you should give it a thought. The chest imaging findings of a patient with interstitial lung disease can be quite different from typical pneumonia and will help point you in the right direction. Let's summarize the presentation of your typical community-acquired pneumonia in a sample assessment statement. Mr. Nemo is a 67-year-old man who presents to the ED with fever, dyspnea, fatigue, and productive cough for 2 days. His vitals are significant for a temp of 39.1, heart rate of 110, and respiratory rate of 28. Physical exam is notable for inspiratory crackles and dullness to percussion over the left lower lobe. Chest X-ray shows a focal left lower lobe opacity. Mr. Nemo's presentation and findings are consistent with pneumonia, and since he has no risk factors for nosocomial or healthcare-associated pneumonia, the most likely diagnosis is community-acquired pneumonia. All right, let's sum up this sketch before we end up like Tentacle Face over there. When pneumonia comes from the community, there are 3 main groups of bugs to think about: typical bacteria, atypical bacteria, and respiratory viruses. Typical bacteria include Strep pneumo, Moraxella catarrhalis, Haemophilus influenzae, and Staph aureus. Atypical bacteria include Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella. Viruses can also cause CAP, with the most common causative agent being influenza. And don't forget that immunocompromised patients and those spending time in endemic areas are at risk for fungal CAP. Hospital-acquired pneumonia, or HAP, starts 48 hours or more after admission, while ventilator-associated pneumonia, or VAP, starts 48 hours or more after intubation. HAP and VAP are typically caused by gram-negative bacilli like Pseudomonas and Klebsiella, as well as gram-positive cocci like MRSA and Strep pneumo. CAP caused by Mycoplasma is more common in school-age children than in adults. What are some of the common chief complaints in pneumonia? Think fever, cough, pleuritic chest pain, and dyspnea. Pneumonia can present as acute onset, often with purulent sputum. This is classically associated with the typical microbes. Pneumonia can also present subacutely, with a dry cough and watery sputum. This presentation is classically associated with the atypical microbes. But remember, the classic typical or atypical presentation is not a reliable indicator of the specific microbe causing infection. Keep in mind that pneumonia can present with delirium or altered mental status in hospitalized patients, especially in the elderly. Secondary bacterial pneumonia, think Strep pneumo, Staph aureus, can occur after recent influenza infection. Patients will have influenza, get better, and then get worse again. Make sure to ask about preceding flu symptoms. Young, previously healthy patients who get influenza are at risk for secondary bacterial pneumonia with MRSA. This is an aggressive pneumonia with high mortality. However, pneumonia can develop directly from influenza infection, where influenza infects the lung itself. Associate this with influenza that progressively worsens, showing high fever, dyspnea, and cyanosis. Aspiration pneumonia can develop when the clearance defenses are compromised. This can occur in the setting of altered consciousness, neurological disorders, esophageal disorders, mechanical disruption, and protracted vomiting. Aspiration pneumonia is associated with anaerobic infection or polymicrobial infection. Though it turns out that most cases of aspiration pneumonia that occur in the community look like CAP, while those that occur in the hospital look a lot like HAP or VAP. COPD is a risk factor for pneumonia, specifically with Strep pneumo, H. flu, and Moraxella. However, COPD patients are also at higher risk for MDR gram-negative infection, including Pseudomonas. Bronchiectasis and cystic fibrosis are also risk factors for infection with resistant gram-negative rods, again including Pseudomonas. If you see recurrent pneumonia in the same location, work up the patient for possible malignancy. Make sure to ask about certain social history factors. This includes whether the patient has spent time in close quarters where we worry about CAP from mycoplasma. Tuberculosis is a concern for those with contact with known TB cases, travel to or birth in a region with high TB incidence, prior positive TB test results, illicit drug use, and high-risk communal settings like prisons and homeless shelters. Patients exposed to contaminated water or ventilation are at risk for Legionella pneumonia. Legionella infection is classically associated with diarrhea, vomiting, neurologic symptoms, relative bradycardia, and hyponatremia. Does your patient work with birds? Think about Chlamydia psittaci. No birds but livestock instead? Think Coxiella burnetii, especially if they have a severe headache and other flu-like symptoms. Make sure to also ask about recent travel. Caves and chicken coops in the Ohio and Mississippi River valleys are home to the fungus Histoplasma capsulatum. Along with pneumonia symptoms, a minority of patients also develop arthritis or skin lesions such as erythema nodosum or multiforme. Travel to the Ohio and Mississippi River valleys or the Great Lakes is a risk factor for blastomyces dermatitis. Look for pneumonia with skin disease characterized by verrucous skin lesions. If instead your patient traveled to the southwestern US or northern Mexico, think Coccidioides immitis. Along with pneumonia symptoms, a minority of patients also develop arthritis. And just like with histo, these patients can also present with skin lesions such as erythema nodosum or multiforme, though this is pretty uncommon. Hemoptysis can occur with any pneumonia, though it's more characteristic of necrotizing MRSA pneumonia and cavitary lung infections such as TB and the chronic forms of the endemic mycoses. Okay, now on to the objective findings of PNA. Look for fever, tachypnea, tachycardia, and decreased O2 saturation from right to left shunt. You might hear audible crackles, dullness to percussion, and increased tactile fremitus. Signs of consolidation include decreased or bronchial breath sounds and agophony. How about for imaging? Turns out that an infiltrate on chest radiograph is generally required to diagnose pneumonia. Infiltrates often appear as lobar consolidations or interstitial infiltrates. Consolidation in dependent areas of the lungs are characteristic of aspiration pneumonia. MRSA pneumonia can cause multilobar necrotizing cavitary lesions and empyema, or pleural infection. TB pneumonia can present with cavities, often in the upper lobes in reactivation TB, or a millet seed appearance. Mediastinal or hilar opacities on chest X-ray can suggest infection with tuberculosis or histoplasma. Lytic bone lesions from osteomyelitis can be seen in blastomyces. Labs will often show leukocytosis with bandemia. In simple outpatient CAP, no more diagnostic testing is needed. For patients with hospitalized CAP or with HAP or VAP, you'll need more workup. This includes blood and sputum cultures, sputum gram stain, and elevated procalcitonin. Viral testing can include a viral panel and rapid flu test during flu season. Test for Legionella and strep pneumoantigen in the urine. If you suspect it, you can also test for fungi. So we've ordered all these tests. Now what? Well, in our next sketch, we'll head on up to the surface. It's treatment time.